All right. Good morning, everyone. Welcome to our every other week, Friday morning, AMSSM Sports Ultrasound Case Series. I'm Brennan Betcher. It is my pleasure this morning to introduce Dr. Ryan Kruse, who will be presenting. Dr. Kruse is a good personal friend of mine. He is one of the innovators that has led to this extensive case series that's been hosted for the last couple of years now. He is a personal mentor of mine, someone I ask questions when I have ultrasound questions to, and he's going to be presenting today on submetatarsal bursopathy. Dr. Kruse is a clinical assistant professor in the Department of Orthopedics and Rehabilitation at the University of Iowa. He is also the associate program director for the Primary Care Sports Medicine Fellowship there. He's a team physician for USA Soccer and USA Rugby. He has received his International Olympic Committee Diploma in Sports Medicine. He completed a physical medicine and rehabilitation residency at Mayo Clinic and his sports medicine fellowship at the University of Iowa. He has a special interest in diagnostic musculoskeletal ultrasound, ultrasound-guided microinvasive procedures, and the use of orthobiologics for the treatment of joint and soft tissue pathology. He currently has multiple ongoing research studies involving musculoskeletal ultrasound and orthobiologics. He's involved in many national organizations. In particular, he's heavily involved in sports medicine ultrasound within the AMSSM, and he teaches extensively at local, regional, national, and at the international level. Welcome, Dr. Kruse.
All right, thanks, Brennan. That was an overly kind intro there. Let me see if I can share, and then we'll get going. Dun, dun, dun. All right, Brennan, can you see that?
Yes.
All right, we're going. All right, thanks again, Brennan, for the intro. It's fun being on this side of things now, and the case series is in great hands with Brennan. And I think this is going to continue to get better and better with Brennan taking over and running things. So it's a bit of a different case, and it's the case I'm going to present is a case of submetatarsal bursopathy, and we're in year three or four now of this, and so we've really built quite a nice library of cases, and we continue to build that library. And I thought this case, while a bit random and a bit different, we don't have any of these cases, and I thought it'd be a nice chance to talk about some of the relevant anatomy and just put this diagnosis on folks' radar, just to know that it exists and be able to identify it, because if we don't know that it exists, we're not going to look for it. If we don't look for it, we're not going to find it. So that's where the idea behind this case came from. All right, so no disclosures. Brennan had to put up with me for a while in residency, and I guess still does have to put up with me, but as does Doug. Other than that, nothing relevant here. So as is always the case, the objectives for this case series are fairly clear and fairly consistent. We're going to talk about my protocol for the complete evaluation of the forefoot. We'll talk about some normal appearances, and then the relevant pathology within the area of interest here, and then we'll briefly go over my ultrasound report. All right, so this case, this is a patient that I've seen quite a bit. He's a 53-year-old GI doc. I'd seen him a couple of weeks before for his knee, and a couple of weeks before that for his shoulder, I think. But he emailed me and brought him in for evaluation of acute left plantar forefoot pain. So he is a avid exercise nut, and when he finds an exercise he likes, he goes at it pretty hard. When he emailed me, he was trying to strengthen his knee for whatever other injury, and had told me that he was doing reverse lunges, and in fact had been doing hundreds of consecutive reverse lunges every single day. And not surprisingly, that may have led to some sort of injury, and in fact led to his forefoot pain. So all of his pain was around the second MTP joint, mostly the plantar region. He had some over the third, but it was primarily over the second MTP joint. Weight bearing was not fun for him. Barefoot hard surfaces, pretty bad deal. And in fact, he was having trouble. He's a proceduralist and does a lot of scopes, and was having trouble finishing a procedural day because of pain in his foot. He did complain of some bruising, some intermittent bruising in the area, again, the plantar region. Also complained of some intermittent paresthesias in his second web space. And he has not done anything from a treatment perspective except stop doing his reverse lunges. On exam, so just looking at his foot, he had fairly prominent plantarly directed metatarsal heads, particularly his first three. He did have some focal swelling, focal edema over his plantar, second MTP. I didn't see any bruising. When he came in, he was tender kind of throughout that region, mostly over the second MTP, but also to a lesser extent over the plantar third. There was this kind of bogginess or fullness to palpation over that second plantar MTP, and the rest of his examination down there was fairly unremarkable. So imaging here, again, this is his left foot. So here's a standard AP standing radiograph here, which is fairly unremarkable. So oblique, nothing really overly exciting here. You can see on his lateral here, he's got a plantar and posterior calcaneal enthesophyte, pretty big Hagelin's deformity here, but this doesn't matter. He's not symptomatic here. This is where his region of pain is, and you can really see these kind of prominent metatarsal heads here. Almost, you probably call this borderline hammer toes here, but this was his area of concern, an area of pain here. So again, this comes from the new curriculum, which we mention every single time we do these talks, and just I'd be remiss to not say that the structures listed in the curriculum are not meant to be comprehensive, nor prescriptive for clinical practice. But they are, a guideline to help us when planning our protocol for all these different regions. So per the AMSSM, protocol, the required structures are the MTP and IP joints, the metatarsal interspaces, plantar plates, flexor tendons, and then the great toe sesamoids. And then optionally, according to the curriculum, we've got the extensor tendons, and then the termination of the medial plantar nerve, the plantar medial helical nerve. So mine's similar. When I have somebody who's sent over for a forefoot evaluation, at least for the most part, these are, at least in my practice, fairly focal pain. Some people point right to their second MTP or, right to their third. And for me, I like to look at that region, but also do or look at a toe region on either side of that region. So typically I'll look at, 3 toes, 3 MTPs, 3 IP joints, so on and so forth. I think it's, at least for me, it's a bit overkill to look at all 5 MTPs, all 5, PIPs or IP and whatever. So I think it's a bit overkill for me. So I typically look at 3 regions unless clinically I decide that I need to do more than that. I always do a plantar plate assessment. I'll look at the submetatarsal bursae. I'll look at both flexor and extensor tendons. We'll take a dive into the interspaces. And then for me, these structures down here are the optional structures if I think that they are clinically relevant. So we'll dive in here. So for this patient, his region of concern, his region of pain was the second MTP. So for him, I evaluated both the first, second, and third. I didn't really look at the fourth and fifth. And I'm only going to show representative images here. I'm not going to show, all 3 MTPs, all the PIPs and whatnot. So if I don't show it here, just assume that it's normal. I just didn't want to be overly redundant here. So when you're looking at most of those structures in the forefoot region, it's important to look at them both, plantarly and dorsally. So in this patient, these are his dorsal images. I did not show specific plantar images of the joints. We'll see them in further slides when we're looking at other structures. And I did not add them here again to avoid redundancy. But here's his area of concern over the MTP joint. Second MTP joint. His pain was plantar. This is the dorsal aspect. So the dorsal aspect of his MTP, second MTP joint here was, fairly unremarkable, maybe a small little effusion here. Down here is his first MTP. The first MTP, the metatarsal head, has a fairly characteristic appearance, fairly large and prominent metatarsal head, versus the lesser toes have some of a smaller appearing and less prominent metatarsal head. But overall, fairly unremarkable here. No real degenerative changes or effusions in the first and third. Like I mentioned, maybe that small effusion in the second MTP joint for what it's worth. And then I didn't include the images here, but the first toe IP and the second and third PIP joints were unremarkable as well. Then I flip over on at this time, I probably looked at the joints on the plantar surface. So now that I'm down there, we'll look at the plantar plates in this region. And so what we can see here, so this is his third MTP joint. We've got distal to the left, proximal to the right. Here's metatarsal head here. This somewhat fibrillar, almost speckled appearing structure here. This is the plantar plate. You can see the flexor tendon over top. We've got fat pad and skin here. So his third MTP plantar plate was normal. If we flip into more of an anatomic axial view here, you can almost use differential anisotropy to differentiate the plantar plate, which is this deeper structure here, from the overlying flexor tendons here. I will always do a dynamic evaluation as well to look for instability. And you can see up in this cine loop up here, there's really no evidence of instability, which is not surprising because the plantar plate here looks stone cold normal. And in this cine loop, you can actually appreciate the differing appearance of the flexor tendon compared to the plantar plate. Plantar plate has more of like almost like a granular speckled appearance versus our standard hyperechoic fibrillar structure of the tendon. This bottom right picture here is his first MTP plantar plate, which has a bit of a different appearance compared to the lesser toe plantar plates, which is important when you're evaluating these structures. Let's see here. So when I'm looking at the lesser toe plantar plates, they tend to have a fairly robust insertion onto the condyles of the proximal phalanx here, and it rather tapers off, almost like a comet tail type appearance, versus the first MT plantar plate tends to be a bit more robust and a bit more sturdy and thicker. And so you can see this here again, this kind of tapering appearance of the third and of most of the lesser toe plantar plates, and almost this trapezoidal or upside down trapezoid, I forget which way is which, appearance of the first MTP. The other thing that I always think about, and I actually just thought about it when I was making this drawing here, is that these lesser toe plantar plates tend to look like a Smurf's hat, versus the first MTP plantar. Wow, that is slow. The first MTP plantar plate is almost like an upside down temple. That probably doesn't make sense to anybody else, but in my mind, that's what I see when I look at this, and I'm sticking to it. So for this patient, first, second, and third MTP plantar plates were normal. No attritional changes, no tears, no instability with dynamic imaging. So at this point, I would probably take a look at the submetatarsal bursae, but because that's our region of concern, we're going to hold off on that for now. Looking quickly at the flexor tendons here. This is the image that I showed previously when we're looking at the plantar plates, but you can see the flexor tendons sitting nicely right on top of the plantar plate. Here is his flexor tendons. The second and third FDL tendons were normal here. A fairly more robust FHL tendon and long axis here looks fairly normal at this point. I did look further distal at its distal insertion, and there was this little kind of hyperechoic focus here that tends the overlying FHL tendon. So I did comment on that. I don't think it's clinically relevant, but we'll go over that a bit later. So for this patient, FHL and the second and third FDL tendons were essentially normal, no tendinosis, no tearing, no sheath effusion. There's a small hyperechoic structure with measurements here. Proximal to distal phalanx with complete posterior acoustic shadowing. I think it's important to mention that because it gives an idea of how hard that calcification is. If it's soft calcification, you're gonna get minimal or no shadowing versus complete shadowing tells you that's a pretty rock solid calcification. or avulsion or whatnot. And in this patient, it essentially tense the overlying FHL tendon. All right, a bit more of the same here. So the extensor tendons were essentially normal. So this is the EHL tendon here. You can see it tapering a bit smaller here as we go distally. You can see it, its terminal insertion here. This all looks normal, and all three, or I'm sorry, both of his EDL tendons look fairly normal here. So nothing super exciting here. Next for me, I'll take a look at the metatarsal interspaces here, and I'm not going to belabor this. There are much more intelligent talks on this area that Doug has done numerous times. So I would encourage folks to view and review any of those talks by Doug. But just briefly, I want to just touch on the anatomy here. So this is an image. Doug was generous enough to let me help out on a chapter with him on ultrasound evaluation of the forefoot region. And so this is an image from that. It is not yet published, but it should hopefully be soon. So looking at the interspaces, they have fairly different appearances depending on which plane you're looking at them in. It's also critical to look at the interspaces both from the plantar and dorsal aspect. So I usually start plantarly. I do that because the interdigital nerve is going to be the most plantar, and I guess from that view, superficial structure. And I can take a quick look at that and obviously assess for any neural abnormalities, any neuroma, so on and so forth. Deep to that, you're going to have your deep transverse metatarsal ligament. And then the intermetatarsal bursa from the plantar approach would be the deepest structure within the interspace. A dorsal viewing approach is quite nice for a couple reasons. The skin tends to be a bit thinner up there, so you can see structures quite a bit better. The other thing is you can apply a dorsally directed thumb pressure from the plantar foot, which will bring all these structures more superficial, more dorsal, will allow you to see those structures better, or also push the interdigital nerve around the deep transverse metatarsal ligament and make that more conspicuous. So, really should look at these both dorsally and plantarly. So just quickly here, so this is the these are appearances both in the essentially anatomic sagittal and the anatomic axial plane here. So we've got metatarsal heads. This is the intermetatarsal space here. So a plantar approach here. So the most plantar or most superficial and plantar structure is going to be your interdigital nerve. You can often see a little vessel right next to it. Deep to that is going to be the deep transverse metatarsal ligament, which provides stability to the metatarsals here, and much further deep here is the the intermetatarsal bursa. I don't know why it says SM. I don't know why it says SM either. So that should be intermetatarsal bursa. And now we're looking essentially in a longitudinal view, or almost an anatomic sagittal view. You can see that interdigital nerve is now the deepest structure on the screen, followed by the DTML, and then the interspace bursa here, intermetatarsal bursa, is now the most superficial structure here. I also like to look at these dynamically, so I'll do a forefoot squeeze, particularly if there's a neuroma, to see if there's a sonographic Mulder's click, but there is no neuroma here, so that all looked fairly good. All right, so we're getting near the end here. So the submetatarsal bursa, I'll be honest, I really didn't pay much attention to this until I, probably got out of fellowship. It just wasn't something I really thought about. I didn't think that it clinically mattered. I really didn't look all that much, or really know all that much about it. But basically, with these submetatarsal bursae, so they're adventitial bursa, so they develop over time, and by saying they're adventitial, they are not synovial lined like other bursae throughout the body. These are not necessarily present in the normal state, but they likely occur after chronic abnormal mechanical stress, which we think probably results in some collagen breakdown. You get this inflammatory reaction and this fibrovascular tissue and fluid accumulation within that region. And we do see most commonly it's in the first and fifth metatarsal heads. or underneath the, or plantar to the first and fifth metatarsal heads. And a lot of that is likely, again, because of biomechanical overload. These are fairly prevalent, I'd almost say highly prevalent in folks with rheumatoid arthritis for various reasons. So that's the idea behind these bursae, and that's how they come about. In a normal state, you really, like I said, because of their adventitial nature, you're not really going to see all that much. So this is the third submetatarsal bursa region here. So we've got the MTP joint here, plantar plate, FDL tendon here. You can, somewhat see a little hypoechogenicity in this region here. I honestly blow that off, but this is the region where you would see a submetatarsal bursopathy here, and in this kind of short axis of the tendon appearance, the bursa is going to be far, I don't know why this got cut off, but far superficial to the flexor tendons. Maybe. There we go. All right, so here's our patient. So his first and third submetatarsal bursae were normal. So looking at his second, you can fairly, easily see here this large speckled hypoechoic structure here overlying the second metatarsal head. When you throw Doppler, I guess SMI on this, and this whole area lights up. So it's got, all this neovessels and hyperemia around the submetatarsal bursa. And dynamically, this was fairly compressible, and looking at the appearance of the fluid within the bursa, the more that you look at these things, simple fluid, whether that be just blood, non-coagulated blood or whatnot, is fairly anechoic, and you can see that this is relatively hypoechoic and speckled, and this is a fairly classic appearance of blood products that have begun to coagulate, and so it's a very different appearance than just simple fluid within the bursa here. And so the read here, at least in my report, says so the second submetatarsal adventitial bursa is significantly thick and heterogeneous. There's a speckled complex, relatively hypoechoic, compressible fluid collection within the bursa, measuring so on and so forth. There's moderate Doppler hyperemia throughout the bursa and the surrounding fat pad. I'll come back to, I didn't make any clinical judgments here. I'll come back to this when we get to the report. These are just some other quick pictures or other representative examples. This is not this patient here, but the point here is to show other common appearances. And most of the time when you're seeing these submetatarsal bursopathies, it's mostly just this inflammatory, boggy, edematous issue and thickening of that bursa, at least what I've seen, rather than just simple free fluid here. So you can see all this hypoechoic tissue within the submetatarsal bursa. It's fairly hyperemic here, like I mentioned previously. This example down here does have some anechoic simple fluid within the bursa that's fairly compressible here, so you have to be careful you don't apply too much transducer pressure. You can compress this out similar to like a prepatellar bursa. But again, mostly it's this hypoechoic, hyperemic tissue that we see, at least that I see down in this region. All right, so finishing up here, the ultrasound report. This is fairly standard for me. This is the way that I like to do it. I think that a lot of folks probably have a similar style as well. The referring provider, facility, why I'm seeing them, study type, as best you can, should almost always be a complete study. Not always. There are certain reasons and indications why you don't need a complete study, but if you can, you should try and make it a complete study. For the plantar foot, I bounce back and forth between a couple transducers. Sometimes in these big, thick farmer feet, I can't really see much plantarly, so I'll use a 14 or a bit of a lower frequency, but dorsally skin's usually fairly thin, so I'll flip to a higher frequency transducer. In my, like I've mentioned in prior talks, in my findings, I'm fairly just descriptive, and I don't really make any assessments or clinical judgments in my findings. So I'll just say exactly what I see. And then down in the summary, I will at times incorporate some clinical judgment here. So for this this patient, the summary here, he's got an acute left second submetatarsal bursopathy. The appearance, the sonographic appearance, as well as the clinical history, would favor a hemorrhagic bursopathy. We actually did drain that at one point, and confirmed that it was hemorrhagic. And then I commented on the that small cortical irregularity at the proximal aspect of the first distal phalanx, which abuts the overlying FHL tendon. Again, now putting a bit of a clinical interpretation or judgment here. Likely presents an old chronic avulsion and is unlikely to be clinically relevant. I can only say that because I obviously assessed and evaluated this patient. So that's a pretty standard report for me. And that is all I got. Thanks everybody for listening and tuning in, and I'm anxious to hear what Doug and Brennan have to say.
Ryan, that was an awesome case. A little bit of an unusual location for that. You mentioned the great toe and the small toe tend to be the most common locations. I'll say I don't see this that frequently, but I tend to see it mostly in the small toe as kind of the primary location. And as you mentioned, usually they're not like massively fluid filled. They're kind of this like rubbery, marbly, swollen, hypoechoic kind of mobile nodule that appears insidiously in people. You also mentioned and I think really highlighted the importance of having x-rays along with this. We frequently see this in people who have that kind of hammer toe configuration where they have really prominent metatarsal heads and maybe aren't taking some of that load through the phalanges of the toes. And so I think that's an important complementary imaging study that is helpful. Other things that you mentioned that I think are super helpful that I've maybe learned the hard way are, I agree with you on changing transducers several times during the forefoot examination, because people who have really thick calloused, kind of plantar distal feet, they're really hard to get a good image with a higher frequency transducer. So, excuse me, even though it's really superficial, sometimes you just really struggle. And if you drop the frequency down or move to a lower frequency transducer, sometimes that makes it a lot easier. A couple other things you highlighted I think are really important, and I'm glad you brought them up, were scanning the couple of regions adjacent. So it's very similar to our physical examination, where you want to look at a joint above and a joint below. You want to look at, the toes to either side, because people are notoriously pretty bad at localizing their pain in the forefoot sometimes. One thing, that you didn't mention that I would say is important in this area is, and I think you kind of looked at it, but is, scanning the metatarsal itself, looking for like a stress reaction or something along those lines, because that's certainly something that early on, especially, you can pick up on ultrasound that you may not pick up on the x-rays. And then the last comment I'll make is that little hyperechoic nodule that you saw underneath the FHL tendon, I don't know for sure, but that seems to me like it may be a subhalical sesamoid, which is something that's not present in very many people, but it tends to be present kind of at that IP joint. And I've seen it a few times under the FHL and several times in other toes. But that can actually cause like a subhalical bursopathy as well. It's very similar. They get this adventitial bursa that's directly plantar to that prominent little subhalical sesamoid. And that's something that I haven't looked into a whole lot, on my own. Maybe Doug has a comment on it, but something that I've seen a couple of times in the past that ultimately turns out to not be an avulsion, but maybe is this little accessory bone.
Yeah, and I just to add on to that, Brennan, your point about the metatarsals, I think is a really important one. And I'll frequently, I don't always, if I have concern for bony injury, I'll look at the metatarsals, because you're exactly right. I mean, I've picked up, I don't know, at least a couple a year, metatarsal stress fractures on ultrasound that are, radiograph occult or radiograph negative. So your point there is important, is really important. All right, Doug, let's hear it.
Oh my gosh. Well, Ryan, as expected, top notch. You know, ultrasound in some regions, in my opinion, at least, has been a game changer, and the forefoot is one of them. I would say, in particularly the lesser metatarsalgias, I have multiple cases of MRs missing significant pathology or underestimating the pathology. And so for those, starting an ultrasound or getting more into diagnostic ultrasound, I think ultrasound the forefoot is fantastic. It's not that difficult with just a little practice. One comment that I think you said, just to highlight, is that it's, in this patient you presented, Ryan, there wasn't a lot of other pathology, but it's pretty common to see beat up plantar plates in addition to, let's say, a Morton's neuroma, or to see other pathology involved when someone has a submetatarsal bursa. And so I think it's really important to help the referring provider distinguish between, what is normal age-related attritional changes and what is symptomatic. So, for example, if I were to see a significant plantar plate tear, but it's not necessarily the cause of pain, then I will say that there is no associated pain or corresponding pain with sonal palpation. And alternatively, I will go ahead and say this is the maximal site of tenderness with sonal palpation. So it's pretty rare. Maybe it's just my population of people. I just see one isolated problem. Differential diagnosis of a submetatarsal bursa. I've seen other things that look like it, but in regards to the bursa itself, you presented a nice case of a hemorrhagic bursa, and that certainly can be the case and fits with the history. I've seen actually truly inflamed bursas. I've seen gout, and I've seen rheumatoid arthritis result in an inflammatory bursopathy. And I've also seen one case of an infectious bursopathy. So people are rubbing through a callus, they get a fissure in the callus has a little submetatarsal bursa. I've seen this more under the first, and it gets infected. And so as far as submetatarsal bursas go, just keep on the lookout for, true inflammatory and infectious. The history should help you with this, but rheumatoid nodules can be in this area. And the differentiation, in my mind, it can be hard, but the rheumatoid nodules are not cavities and typically don't have fluid in them, but they can look very similar. And rheumatoid nodules have a fair amount of heterogeneous appearance. They can have some Doppler activity. They may not have Doppler activity. They can be associated with a callus. So just be on the lookout that rheumatoid nodules is in the differential diagnosis. Another differential would be a plantar fibroma. So we think plantar fibromas are just classically in the central cord of the plantar fascia, but just remember that the distal plantar fascia sends off very fine slips to the plantar plate. And anytime you have potential plantar fascia tissue, you can get a fibroma. And so I've seen fibromas in places that I was really surprised. And this is one of them that, because there's plantar fascia tissue to the plantar plate, you can get a fibroma. And then also, we don't think about this, but tenosynovial giant cell tumors and the flexor sheath in the forefoot area. There's multiple case reports. I've seen one case of this. And so that would also be in the differential diagnosis. And then I just have a question, Brian and or Brennan or anybody else. So we see the classic submetatarsal bursa, it's not hemorrhagic. There's no concerns about infection. It just hurts. It's a little fluid filled. Have you guys ever injected these? And if you have, what has your experience been?
So I can touch on that really quickly. So I try to not. I think maybe I've put steroid down there twice, and then I've aspirated it. I don't know. I just get hesitant, putting steroid, in and around. Obviously, this is not in, but it's around the plantar fat pad, whether at the heel or at the forefoot. I just get nervous, causing further attritional change or atrophy within the fat pad, which is obviously something that we can't fix. So I tend to stay away from it. That might be a fairly controversial comment, but that's my my typical thought process. I don't know, Brennan, do you inject these?
Doug, I tend to initially start with trying to do orthotics and excavate that area to try and offload it a little bit. I think a lot of the times these seem to be related to biomechanical changes in the foot where they have this kind of plantar flex metatarsal and then dorsiflex, phalanges. And so people are really overloading that kind of metatarsal head. So I try and excavate that if I can, and maybe use like a metatarsal pad to offload that. If that doesn't work, I will inject these. And Ryan, kind of the side effect that you mentioned of steroids, causing like fat pad atrophy. I'm actually trying to use that side effect to my advantage in this by putting a little bit of steroid directly into that hypertrophic tissue to try and shrink it down. And I've had a couple of patients that have had really good long-term relief from just a really low dose, one-time injection. And I've had a couple of patients where it works temporarily, but then it comes back, at some point down the road. And those are the ones that I don't really know, what to do with going forward. Is it right to, keep doing those, or those patients that would be benefit from something different? It's a tough question. You certainly don't want to cause that forefoot fat pad atrophy, because you will make someone quite miserable.
Yeah, I mean, I haven't injected these at all. And I've had a few sent for an injection. And so, Brennan, I've taken the same approach, but there are some people that are just miserable. And if somehow you can settle down the tissue, I've thought about it. So it's nice to hear that, at least in the some that you have injected, at least has provided some relief without complication. I don't, it's a question that I think we'll get a lot of different answers. And I was just curious to see what you guys do.
Brennan, what approach do you take? How you come at these?
So I've injected a couple that are like that subhelical sesamoid underneath the great toe, FHL kind of distal insertion. And those I just come from like a medial to lateral inplane into that hypertrophic bursal tissue. And I would say actually the majority of the ones I've done have been underneath the fifth metatarsal head. And same thing, I'll do that kind of in-plane lateral to medial approach, and from the plantar surface of the foot. And I'll really target being inside of that hypertrophic tissue. I don't want anything to go anywhere else. I use a really low volume, so I don't have a lot of kind of extravasation of that medication, and it'll be directly into that hypertrophic bursal tissue.
Okay. Yeah, that makes sense. And I think just one last thing for me to add, I have seen a couple times, one actually just recently, where a patient was sent to me, for forefoot pain, but it was dorsal MTP pain, and this most recent patient was at his fifth toe, and after scanning, I probably should have added that image, but after scanning him, this was all a large submetatarsal bursopathy, a fluid-filled bursopathy that had this weird, like, lateral dorsal extension. So it was kind of coming up and around the lateral aspect of his fifth metatarsal and sitting, fairly far dorsal. So because of where his pain was, I certainly wasn't expecting a submetatarsal bursopathy, but just something else to point out that you can see that also.
I've also seen it erode into the intermetatarsal bursa. So it can,
sure.
Yeah, really extensive.
Well, excellent work as always, Ryan. I can't thank you enough for putting that presentation together. That was incredibly helpful.